So it's really great to see how many people have joined. Welcome. Welcome to today's webinar. My name is Stefan Mandic-Rajcevic, and for the next hour, I will be the moderator of our meeting, of our webinar. I work at the Faculty of Medicine, University of Belgrade as a researcher, and I was a researcher for Media Education Center on this project. Also, Media Education Center is one of the AHEAD team members. The AHEAD project, meaning Action for Health and Equity Addressing Medical Desert, aims to reduce health inequalities by addressing the challenge of medical deserts and medical desertification in Europe. Our team consists of the Center for Health Policies and Services from Romania, Cittadinanza Attiva from Italy, Media Education Center from Serbia, the National School for Public Health Management, Moldova, WEMOS, lead partner organization from the Netherlands, and VU Athena from the Netherlands. So before we start, and you can see in our chat, I would like to mention some of the house rules for today. So first, if you have any questions during the webinar, please write them in the chat box. We have behind the scenes our colleague Pearl, who is looking at what you write, and she will help us be able to answer all the questions. Feel free also to use the Q&A box in Zoom. We will be monitoring all these ways for your input. If you wish to speak, raise your hand. I see Mario Leone has raised their hand, so do you want us to let you speak, Mario? Let's see how this works. Maybe it's by accident.
Actually, he put a question in the question and answers, and we will answer it offline.
Okay. So just so you know that the webinar is being recorded, and we will share the link to the recording very soon after the webinar is finished. So the first thing I would like to ask all of you, and I ask Pearl to share the access to our Slido. And the question that will be, what country are you connecting from? This is really important for us because we would like to understand where you're coming from and then also why this is of interest to you. So Pearl, if you can please share the Slido link. Thank you very much. When you click on the link, you have the possibility to put one word. So in the chat, you have the link, or you can go directly to slido.com and put our meeting number, but I think it's easier to here is the link again. So for now, we have the Republic of Moldova, Netherlands, UK, Serbia, Romania, a lot of people from the Netherlands, obviously, Poland, more people from Serbia. So obviously Poland and the Netherlands, the most participants come, and then Serbia, Italy, Belgium, Slovakia, Finland, and the UK. Just so you're ready, in the same window, definitely Netherlands, Serbia, Poland, Belgium, Romania, Slovakia, UK, Finland, and Italy. So I kindly ask Pearl to put on the next question. The next question needs to help us understand what is your interest in this webinar. So why are you joining us today? What's motivating you to spend this time with us and to hear what we have to say, and maybe share your experience with us? We have some answers: how to measure medical deserts across different countries, how to identify medical deserts, getting new knowledge, learning. To learn more about medical deserts, to understand how the tool that we're going to present works. So most of the participants want some new knowledge, to learn how to understand, not only here we have a new one, not only how to identify medical deserts, but to see what the impact of medical deserts can be, to understand our tool, to see the new tool, to understand the tool, to understand how to use it, how to measure. So this is really encouraging to us. It shows that our work really is interesting to you, and I hope we will be able to give you what you came here for, to give you all the information that you need. Again, feel free to use the chat box or to use the Q&A section of Zoom to ask any questions that you have. Perfect. Innovative and new tools to understand how to measure and monitor medical deserts, identify. Perfect. Thank you, Pearl. I'm going to close the poll now so we don't spend a lot of time on this. So as most of you obviously have understood, during the next hour we will try to show you how the AHEAD's Medical Deserts Diagnostic Tool has been constructed and how it can help contribute to effective policy solutions to address medical deserts in Europe. Medical deserts are obviously a public health problem. When you think about how many European health systems are becoming overburdened, not only because of an aging population, which leads also to the increase of chronic diseases and comorbidities in this population, requiring long care, but also we have the workforce in European countries which is aging. There are waves of retirement of health personnel, which strains additionally the healthcare systems of Europe. And on the third side, we have many budgetary constraints and financial cutbacks because of high spending to healthcare in most European countries. And if you add to this also the migration patterns, there are severe health workforce shortages in many countries. So this new issue that we are trying to tackle with this project is named medical deserts. The medical deserts are areas with limited health services that result, in short, in unmet health needs. These unmet health needs are the problem of the local population, and the final result is health inequalities. Our worry and the worry of European countries is that this is something that's just going to intensify over the coming years. One of the main goals of this project is to support policymakers in their efforts to counteract and prevent medical deserts and medical desertification. So what is the big problem here? How can we make policies for medical deserts and counteract medical desertification if we don't know how to identify where medical deserts are? We are not sure how to define medical deserts, and we are not sure how we can monitor medical deserts. So it makes it really difficult not only to decide where some activity or action is needed, but also how are we going to know if we are successful or not. To make this possible, our project has worked on creating the Medical Deserts Diagnostic Tool, which should be a replicable approach to finding areas at high risk of medical desertification that need to be contextualized to identify medical deserts in European countries. So this tool has been published on the AHEAD website as online interactive maps. So the output of this tool is available at the AHEAD website. I will ask to share also the website in the chat when possible. So the first thing that you can see is you can identify the areas with a high risk of becoming a medical desert. Then it's possible to monitor medical desertification, to understand quantitatively if there are changes in the level of desertification observed over time. And this is, of course, possible when you have time series of data that you can use, so you can use the tool several times. And this tool is also part of a package which you will see when you come to our website, which include the updated definition of medical desertification, the stories and lived experiences of people living in areas which are identified either as medical deserts or places at risk of becoming medical deserts, and then country-related indicators, country research report, and applied methodologies. Of course, we've mentioned several times, and I think you will hear this, that each country needs to contextualize the approach according to its own need. The underlying methodology of the tool is made available for other countries and interested parties, so you can build a similar tool and calculate the indices. So now I finished with this short introduction, and I would like to hear from our panelists. And we have used the tool to identify places with possible medical desertification in Italy, Moldova, the Netherlands, Romania, and Serbia. So I will give a few minutes to each of our panelists to answer a short question. And maybe if there is a question by the audience, we'll take it a little bit later. And then we will show you also how the tool was developed, how it was used, how you could use it, etc. So I will ask kindly first Bianca to explain a little bit about the reasoning for the choices of specific indicators that were relevant in the Italian context to identify medical deserts.
Thank you, Stefan. Yes, actually, from the literature review and the analysis of the data available for my country, it emerged that medical deserts are still an unknown concept in Italian context, despite several common patterns and trends implicitly refer to the condition of medical desertification. And so from the results of the research conducted, we realized that geography is a key factor. And in fact, distance and rurality represent a cost, time, and distress barriers for patients in accessing primary and preventive care. And also it emerged that in these areas, the shortage of health personnel is associated with poor access to care and medical services, and often goes hand in hand with inadequate territorial care and medical facilities. For these reasons, we focus on analyzing data concerning health professionals with key roles in ensuring adequate healthcare for citizens and patients, as GPs, pediatricians, OB-GYNs, but also cardiologists. And in addition, the key role of pharmacies was confirmed. So in Italy, we conducted 2 different pilots projects in 2 different inner areas, which had medical desert characteristics in 2 different regions, Campania and Sicily. And I admit that we had quite a few difficulties in finding official data because unfortunately, in many cases, they are not public, or worse, they do not exist. But luckily, the widespread presence of my association throughout Italy had assured us that we have an interesting and realistic overview of the situation of these local realities.
Thank you, Bianca. It's really interesting, and I think as part of the research team for Serbia, I think we will see and maybe hear from other experiences that there is often the problem of data availability, how it is shared, and also it's interesting to hear how you have managed to contextualize medical deserts and see what are the priorities specific for Italian scenario. And this is something I think we will hear throughout this webinar, that it's necessary to contextualize the definition and the criteria for medical desertification in each country. So thank you very much, and also thank you very much for keeping the time. So I will go to our next panelist, and I ask Sergiu, in Moldova, what was the most interesting finding during the investigation of high-risk areas? Did you find anything surprising?
Yes, sure. Of course, we find something surprising. Besides gathering data and using the maps that surely offer a great overall view on the medical desertification process in the Republic of Moldova, we also tried to generate some valuable information for the policymakers using this data. And beside this, we understood that the AHEAD project is also offering more than just an instrument or a medical diagnostic tool. It also offers the patient, the citizen's point of view on a medical desert. And the medical desertification process also can be described not using only data, but using the stories, the patient view. And also AHEAD provides this segment in the research area. So we wish and encourage you to access the AHEAD Health site and the section stories in order to check what is the patient's view from each country. For example, the Moldova story focuses on an elderly person who lacks access to primary health care, and he struggles to get proper access to the health system, thus providing a glimpse of understanding what it's like to live in a medical deserts area. Not only numbers, but a voice for the population. So encourage all the participants and spread the word. Access the AHEAD site and check, besides the indicator, the country reports and the medical desert diagnostic tool, also the stories segment. So thank you.
Thank you very much, Sergiu, and thank you for mentioning the stories, because I think in public health, storytelling is becoming, again, a very important source of motivation and a method for knowledge sharing. And you know, it's something that's used even in business. You have the customer persona, and in this case, you can understand that thanks to the stories, we have the typical persona and what this persona's problems are in different countries. So this also helps define medical deserts. Now I have a pleasure to ask a question to Milena from Serbia. So how easily did you find the tool's contextualization process? Was it easy to use, and what were the main findings?
Thank you, Stefan. As part of the research team of the AHEAD project, for us, the contextualization of the MDDT tool was a necessary step before its implementation, because contextualization is the process of modifying the original MDDT materials to make the mapping more meaningful to every country context, including Serbian context, and more meaningful to our local and national stakeholders' expectations and interests of patients and population at the settlement level. Therefore, it was a very essential step that assessment methods are fully adapted to the needs of the population of Serbia and at the same time well aligned with the organizational context for primary emergency care. Contextualization indeed was easy for us for two reasons. First, the regional MDDT requires very basic information about health workers and the population, which Serbia and all other countries in Europe region already regularly reports to national statistics, and as well at international such as WHO, Eurostat, etc. And Serbia has traditionally very well standardized health information system, also very regulated medical documentation and reporting obligations for health facilities. And the second reason it was possible for us because our team has a good level of expertise in HRH and health services research. Nonetheless, since we also wanted to use the latest data as much as possible for describing the current local situation, we had to make a significant and creative efforts while collecting data during the pandemic years. Therefore, the contextualization of the MDDT in Serbia was done by doing the following. First, we inserted data into the MDDT for the years before and during the COVID-19 pandemic. And this was the only meaningful way to assess the potential medical desert currently and avoid temporal biases at the same time. Secondly, the results generated by MDDT index were evaluated in that way through interviews, in addition to interviews and focus group discussions with local and national stakeholders. And finally, we added a new set of indicators to the minimum data required by the original MDDT index. And that particular upgrade helped us avoid selection bias and was used to confirm or test the result generated by the original MDDT index. Therefore, with contextualization, we reduce the risk of alienating our stakeholders, losing their interest in our further work, and avoid it being inconsistent for international comparisons on the other way. But an equally important job in this regard is to maintain the interest of actors in our work through continuous, transparent, and updated information and networking. Therefore, I also call you to look at our AHEAD project website and MEC websites. Also, we have presented our work at the conference in Berlin, so results are available in European Journal of Public Health supplement. Thank you for now, and I'll be happy to take questions from the audience later. Thank you.
Thank you very much, Milena, and also thank you for combining the information that was used. So not only quantitative data, not only qualitative data, not only contextualization, but also thinking about the context. And this project started at a strange time. So it started during the pandemic. So obviously some modifications and deeper understanding is important to better understand the problem of medical desertification. I have now the pleasure also to ask Corinne from WEMOS about the Netherlands experience. I know that Netherlands already had an excellent data collection and maps in the past. So what is the added value of using the MDDT, the Medical Desert Diagnostic Tool, in comparison to the maps that were used before?
Yes, thank you, Stefan. That's a good question. Just a double check, can you hear me well? Yes, okay, because we had a couple of issues prior to the webinar. Yes, thank you, Stefan. Indeed, in the Netherlands, we are quite blessed with good data that are easily accessible also, for instance, through our Central Bureau of Statistics. But we did do some additional tweaking and recalculations in order to get more fine-tuned data for this project. And there are 3 points that I would like to mention here as the most interesting ones. And please bear in mind that we focused specifically on GP presence in the municipalities, as this was one of the most important manifestations of medical desertification mentioned by the respondents in our research phase. So to begin with, we did not only download the data on the number of GPs per municipality, we also downloaded, again from the Central Bureau of Statistics site, the population data per municipality. And this allowed us to do two things. First of all, we could calculate the number of GPs per population, not just per municipality. That is obviously already a big improvement. Second, we also had the data on the age composition of the population in our municipalities. And as you know, health needs vary across age groups. Elderly people have more health problems and require more health and care services. And the youngest age groups also consume relatively more health services, thanks to good neonatal and childcare programs. So with the help of a literature-based formula, we could then recalculate health needs per municipality and compare this with the number of GPs per municipality. This is visualized in our maps as GPs per municipality per 100,000 population adjusted for age groups. It's quite a name, but you now understand what this is about. So these maps give you a more detailed picture of GP supply versus the GP demand, and is relevant because, as we have found, and as many of the participants will also know, many of the areas at risk of medical desertification are areas with an aging population. So it's important to take that into consideration. Additionally, and that is the third point I wanted to mention, and thanks to NIVEL, the Netherlands Institute for Health Services Research, we have been able to also use not just the number of GPs per municipality, but the full-time equivalent of GPs per municipality. And this is obviously very relevant for countries where GPs do frequently work in on a part-time basis, such as in the Netherlands. So again, here, contextualization is everything. And luckily, we had access to those data through NIVEL. So all in all, we did our best to combine interesting data sources, interesting different data, and we applied a few additional calculations in order to obtain more detailed and more context-specific data on GP demand versus supply. And yeah, our hope is, of course, that this helps policymakers to take more adequate and more context-specific actions, policy measures. Thank you.
Thank you very much, Corinne, for the description of how MDD tool was used in the Netherlands. And I would just like to conclude this section by saying that it's really great to see that, again, most of all of the partners have used the tool not only as to analyze quantitative data, not only to analyze qualitative data, but the approach was used to combine quantitative and qualitative data, and then also to enrich the existing quantitative data to better show the context. So not only the number of GPs, not only the number of GPs per the number of population, but also trying to understand how this population uses the services, if there are any unmet needs, etc. So it really offers from a really up in the sky, high level approach to a very low level approach, understanding really how the health system works in a specific country. Now I'm really happy that we have our colleague Mirela Mustata from the partner organization, the Center for Health Policies and Services in Romania. And Mirela was heading or was in the team that led the development of the tool and the index calculation. And we will go a little bit deeper in how the index calculation was developed and how did this process go. So I will start with just a short question for Mirela. What did you find during the research in Romanian context, and what makes this so unique, and how you came to develop the index methodology?
Thank you, Stefan. I think I would need slides for maybe make it more visual. I will explain first how we did the index calculation, because that's the chronological order, so to say. And then exemplify with the Romania case study. In fact, in the initial stages of a HEAD project, as my colleagues referred earlier, we had a literature review process to better define the concept of medical desertification. So using more than 100
presentation view, so it's a little bit larger. F5 or the little icon next to the Zoom.
That means teamwork, isn't it? Good.
Thank you.
Thank you, Paul. Okay, based on more than 100 articles, we concluded on the working definition to inform development of the research tools. And we did, in fact, the research process. But also, the literature review taught us the need to consider both demand and supply when calculating a medical desert index. And as Corinne said, demand is manifested by differentiation with age groups of local population. And by local, we mean both population from one locality, but also the ones in the nearby, which may access the services and the locality under scrutiny. We also mean supply on the other hand, and by supply, we mean general practitioners, pharmacies, hospitals, other type of medical staff, but also the nearby localities. All these principles translate into computing indexes of access to health services that are described in our Medical Desert Diagnostic Tool. And the index calculation methodology, which is included there, it's an example on how we did it for Romania as a case study. In our example, computing medical desertification index or access to healthcare index, we thought we need to consider at least 3 types of providers of medical services: general practitioners, pharmacies, and hospitals. And second, the population adjusted by its structure and the context given by the nearby localities. Once the key medical desert factors are investigated, understood, and compared to national standards, and where possible computed in a set of indexes, one can make a conclusion on the stage of the process of medical desertification. On the screen, we have the example of how we did the calculation for the adjustment to the population needs. And other research team can decide to adapt, of course, the research and index calculation methodology to their specific context and needs. For instance, they might look for a specific medical specialization and population weight characteristics related to that, like gynecologists, for instance, and women population. In the next slide, we have the example from Romania, and this is, in fact, the way we exemplified the index or use the index to do the research in our country. Only a few words about the country. It's a country situated in the southeastern Europe, member of European Union since 1st of January 2007. According to the World Bank classification, a high-income country with a population in 2021 of a bit more than 19 million. Here, life expectancy at birth was 72.9 years in 2021. The country has a mandatory health insurance system, and public health expenditures as percentage of GDP was 6.27 in 2020. So this is the context in which we investigated access to health care services by doing, on one hand, following, so to say, the beneficiary or the patient path within the system. And we did so by looking at the primary healthcare, expressed in number, density of GPs, pharmacies, and access to specialized healthcare. And we looked at the availability of such services in Romania in each locality and the density of such services. On the other hand, measuring access, as I said, meant to look at the needs of the population, adjusted based on age groups, but also considering the characteristics of the population from the neighboring areas. By using these two dimensions, we constructed the medical desert picture, so to say, and this helped us defining the maps of access to each type of services. In the Medical Desert Diagnostic Tool, we have now 8 maps, out of which on the screen we have 3 of them, color-coded from the light blue, lowest numbers of professionals per population needs, to dark blue, highest number of services per population needs. The first one represents number of GPs per adjusted 10,000 inhabitants and considering the neighboring localities as well. The second one refers to the pharmacies per 10,000 adjusted inhabitants at locality level. And the last one is the map of hospitals, number of hospitals level 1 to 5 per 1 million adjusted inhabitants for a catchment area of 30 kilometers. We didn't stop by doing the maps. We also continued validating them, and using qualitative research, we came up with several conclusions. First of it, a lack of general practitioners, especially in the rural side of the country, due to the tendency of the young professionals to remain in the university centers upon graduation of their studies. The second one, it's very important, limited access to preventive healthcare. The third one, long distances and lengthy travel time to reach an action point, especially for hard to reach localities. And that means that aging population have to travel tens of kilometers to receive their prescription. We have also the conclusion that patients in Romania need long waiting time to receive medical services, and we have very rare home visit to patients. And the general conclusion might be that despite the country economic growth, health spending has remained very low, which is reflected in the health status of the population, and still low life expectancy compared to the EU level. Again, many thanks, and if any questions, I am happy to answer. And I hope, Stefan, that I answer your questions.
Thank you very much, Mirela, for this beautiful presentation, and I hope this clarifies some things also for our audience. So let's do the next thing. Let's see if there are some questions from the audience. I'm looking also at Pearl. I'm looking at our Q&A part, and if someone from the audience wants to ask a question, feel free to do it. So you can do it using the Q&A box in the Zoom window. You can send it through chat. So I'm going to ask then, while we wait, I'm going to ask Pearl to play our last Slido poll to see what our participants think. So if you haven't already, please use this link. I'm going to reshare it. Use this link to join us on Slido, and you can answer the last question. So I think that there is a mention always of healthcare data. Healthcare data is always better if it's visualized, and maps are really a good opportunity, good way to do it. I see that the word yes came up as frequently mentioned, so this is really good. People plan to use this. So I see the problem, probably the problem of availability, and that would actually, this was going to be my next question, both for the audience, if someone wants to share their experience, but also for our participants. So what is your take on the availability of data, and how easy or difficult was it to find the data necessary to use the Medical Desert Diagnostic Tool? And then also for our participants, if you haven't, and I imagine you have not used the tool, what would be your steps? Where would you go looking for the data, and how would you use it for the tool? So this is first my question. I'm going to see if there is someone in the audience who has raised their hand. So if you would like to talk, please raise your hand in the audience, and or write in the chat. If not, if any one of our panelists wants to share their experience with finding the necessary data. Yes, Mirela, please.
Yeah, indeed, finding data is not easy, especially because it's a complex type of investigation. But in the end, we discovered the data, we reconstructed the data, and were able to provide the necessary content and the data needed for the calculation and for generating the map. So it's not an easy process, especially because there is no interest so far or defining such maps. But I'm sure that in future there will be more interest, and we are part of this, let's say, future. We are trying to do the advocacy for the needed data and the maps, so that to help decision makers come up with the right intervention. Thank you.
Thank you very much. Does anyone else want to answer? Sergey?
Yes, also I want to point that during our collection of data, we understood that not all local level community representatives want to share their data, because some localities do not consider themselves as a medical desert. So in a way, using a standardized tool at national level helps break the ice, and not to point like this is an area with difficulties or with shortages, but to use the tool to pinpoint the interest of policymakers to think about the tools, the mitigation process, the solutions for this, not only to underline that this is a problem, but this is a problem that needs to be resolved, needs to be highlighted in the policymakers, in the national stakeholders discussion, and maybe to provide this local level solutions from downtown, from villages, for example. So it's quite a tricky process for us, but fortunately we came with the data and provided the maps for Moldova also. So, thanks.
Thank you very much. Would anyone else like to comment on the use of data and availability of data? Does anyone from our audience when thinking about using the Medical Deserts Diagnostic Tool, do you see that you would have some obstacles, or is there, how would you go about it if you want to share your experience? So we have a question, is there any information data you would have liked to include in the tool that you weren't able to? And I asked Mirella to answer this question.
Yeah, I did.
Ah, you did, sorry.
Yeah.
In
fact, it was no, we had all the data, but some of the data we had to work on to reconstruct, so to say, to put together the data from different sources and to finally to get what we needed. It was not easy because they were not available in the way we needed it.
Thank you, Mirella. And I see Milena also has an answer for a question.
Yes, thank you for this very important question. We also wanted to include information about the vulnerable population groups, such as not very often included in representative health surveys, like Roma population, like migrants, but as I said, there were no representative data for these population groups, but we tried to find the answers from during our focus groups interviews and interviews with stakeholders in order to get these aspects also into calculation. Yes, thank you for this important question.
Thank you very much. And if I don't see any more questions, I see, Corinne, please, I see your hand up, please.
Yes, thanks. Yeah, a small addition to what Milena said, because I totally agree with her. That's it's important as well as difficult to retrieve those data. Along the same lines, what we have now done, as Sergio has so eloquently pointed out, we have included stories of lived realities of patients, community members, also health workers, by the way. But it would, of course, be ideal if you would have also data on a very granular level, actually, on unmet medical care needs. And with those data are available from the SILC database, but it's a much higher aggregation level. So it doesn't serve our purposes. So in the next iteration of these projects, so to speak, it would really be nice to develop a tool like a self-assessment tool or whatever that you then can include alongside the quantitative data. Thank you.
Thank you very much. And if I can only conclude this part of the discussion with one of the, well, my impression regarding the availability of data. Even when the data was available, when we were working on it, the problem is that it was not ready to use. So there was a need to work a lot on the data, to put it in the right, I don't want to say, in the right shape. So it would be possible to analyze it in the way which is, so it's not only about sharing the data. There's a lot of data shared in, for example, in some publications which are available in PDF form, but the underlying data is not available in the way which allows to import it, to work on it, and then to use it. So it would, maybe it sounds like a technical issue, but if you want to follow something throughout the years, you want to automate the process, and you can automate really the process of creating maps and following this issue. So I would really want, my recommendation would be to work with the institutions to try to make the data readily available in the form, in the format which can be used by analysis software, by the mapping software, etc. So I will now move on to, okay, maybe there is a new question. So I have two questions now from Marcus Schneider. One is, how do you deal with differences in criteria, for example, for GP density? And how do you deal with temporary changes in needs, so the time dimension? So is there someone who wants to answer this?
I can give it a go.
Feel free.
Thanks, Marcus, for this question. Good to see you here. Temporary changes in needs. Well, that would relate to what I said in my last intervention, is that if you would have regularly collected good quality data from the populations on unmet health needs or unmet medical care needs, I think that would, at least if you then juxtapose those data with availability data, the quantitative data, that should give you a flavor of whether supply meets the demand. So I have tried in the Dutch maps actually to also make a time series on the GP availability. Not so easy, well, in the sense that I have the data, but they stop at 2019, if I'm not mistaken. So there's also an issue there. But I think that could be a way out. As regard your first question, how do you deal with differences in criteria? For example, GP density, I'm not entirely sure if I understand that question. So I'm also looking at my colleagues here. GP density, we have given it a certain value in the Netherlands. And I think that my colleagues did it in a similar way, actually, but maybe I can revert to one of my colleagues here. Thank you, Marcus.
I'm not sure if I can answer also fully, but the idea is that we looked at the density of GPs in one locality, and also we considered the fact that some of the GPs have part-time jobs in other localities, and we calculated the index so that to cover both these full-time and part-time type of services provided. But again, in the index calculation methodology, we explain how we did it. I'm not sure if this was the meaning of the question, but this is how we proceeded.
Milena, feel free. I see you have your hand raised. So
yes. Yeah, I think this is both are important. Yes, I see the additional question here. Both are important questions. So first of all, maybe differences are really explaining the contextual differences. This is very important. First of all, and we will in our final report, we will for sure address this issue. But we, for example, wanted to also be sure that we provide actual situation. And you know, during pandemic, we had some changes in the workforce as well, not only in the needs of the population. Therefore, particular questions that were addressing the patient situations were also differentiated by inserting the question like whether this was only attributed to the pandemic situation, or this was also before situation which was only confirmed during pandemic, or in another way you saw these the changes. So we were trying also to address whether something was exacerbated during the pandemic and or was diminished during the pandemic, but we did not pose questions.
we are losing you, Milena. I don't know if you can.
The people, and also being able to.
Yeah, unfortunately, Milena's connection. Can you hear us, Milena?
I don't know if you can hear.
Now we can.
hear me? Sorry, but this was actually, I don't know where you could hear me before.
We have lost Milena again. So Corinne, you wanted to conclude, and I'll see if Milena connects.
But
Yes.
this was actually the
Does anyone want to continue?
Yeah, can I intervene here, because I now understand what Marcus meant. He says, yeah, I meant the European differences in densities. Yes, yes, totally relevant remark, of course, because when you compare the Netherlands situation with the situation, for example, in Romania or Moldova, we're talking about completely different densities. So relatively speaking, the Netherlands doesn't have a problem with medical deserts. But if you look at the Netherlands itself and zoom in on what is happening in municipalities or somewhat bigger areas, and you see a deterioration of GP services supply, then it is still a problem. Because even if it is, absolutely speaking, of good quality, you wouldn't want it to be much less than it was. And especially if you would then be able to compare it with unmet medical needs, for example, you would have a good picture if you're actually in a medical desertification situation where supply is diminishing and health needs are not met anymore. So there's the question about what is relative, what is absolute. But thank you for the question, Marcus. Thanks.
Thank you very much. And I will now, because we're at the time, I will just go to the conclusion. First, I would like to thank everyone for participating and maybe show or explain what our next steps are. So please share the last slide so people can see where they can connect with us, how they can connect with us. And I will just say that, you know, consensus building is an important element of policy option development, and this will ensure inclusiveness of perspectives of different groups. The AHEAD team is organizing national level consensus building sessions, and we are also starting the preparations for discussing EU level policy options, which will be held online and in person. We want to ensure that key EU level stakeholders and relevant decision makers are engaged to ensure joint reflection on the effective, feasible and acceptable policy measures for addressing medical deserts, which are of course relevant for the context of our country as well as other countries with similar contexts. Please stay connected to us, because our next AHEAD webinar will be on consensus building. And we will announce the date and more details soon. So follow us, and you have on your screens now, follow us on our social channels, sign up for our Medical Deserts networking newsletter. And again, thank you very much for being today with us. And I hope you join us also next time. Again, if there are any unanswered questions, feel free to write to us. We are really happy to reply and to organize individual meetings. Visit our website for more info, and have a nice day, and thank you again.